Government Villupuram Medical College for her Ignite talk. Ma'am, we welcome you. A gentle reminder to maintain the timing for the lack of timing for the session.
Good evening, everyone. I thank God for this opportunity given to me. At the outset, I bring greetings from my department, the Department of Forensic Medicine, and from my college, Government Villupuram Medical College. My talk today is titled, Use Dice to Fill the Gap, a Time to Introspect. Disclaimer, this is no direct personal attack on any of the health professional educators present here. Nevertheless, it is a veiled attack on each one of the health professional educators on the dais and off the dais. I have been a medical teacher and a mentor for more than 2 decades. And this talk is the outcome of my experience and observation and feedback from my students. At present, all of us know that there are a lot of problems encountered both in the student community and in the HPE community. First, I'll talk for the health professional educators. All of us are under a lot of stress. To name a few, poor selection process of the medical teachers. All of us sitting here, while we admit our children, what do we look for? The curriculum, the syllabus, the playway method of teaching, Montessori teaching, even for kindergarten. But what about us? The moment you become PG, you teach your UGs. There is nil training. So then there is nil training once we enter the college also. Every college has a medical education unit. But to be frank, how many of our faculty are really interested in FDPs? You have to just call them, remind them. And then the publishing and promotion. A threat, a Damocles sword hanging about our heads all the time. Then peer pressure. We always look among our friends, peers. How many of them have published papers more than me? We always know. Publications, journals, articles are feathers. There are unbelievable number of papers published even during the COVID time. Around 70 papers by a health professional educator. Now, about our medical students. Our IMGs are like lost sheep, most of them wandering without aim and hope. The reasons may be many. They are really in a mess. The first M stands for monetization of the medical education. And then the second is efforts taken to enter into the medical stream. NEET, repeaters, reduce eligibility criteria. Then S will be for the shortened duration of the professional years. And then self-centered faculty. The societal expectations is just growing in leaps and bounds. So I am a student from Thiruvannamalai Medical College, and I can fondly remember all my teachers, doyens in the fields of medicine. We didn't have AdCom classes, but we emulate, and they are role models, not just fickle icons which we look up. Now it is for introspection. Each one of us can introspect. And I wish to recommend 4 important EPQs. In the morning, you were hearing about EPAs. Now this is EPQs from my side. Expected professional qualities. The first one is discipline. Are we disciplined to that level that we are in a perfect role model for our students to follow? It does not matter which specialty we belong to. Do our students see us as a disciplinarian, both in your private and professional matters? Integrity. How truthful are we? Do we manipulate our students? Are there microaggressions, bias, any discrimination in our attitude? Commitment. Are we committed to our professional work? How far? Are we committed to the welfare of our students? Do we understand their stress? How do we mentor them? Is it real mentoring or virtual mentoring? Do we walk or talk? And then excellence. Do we excel in whatever work we are interested with? So let us be warm demanders. Warm demanders in educations are teachers who combine genuine care and strong relationships with high academic and behavioral expectations, believing all our students can succeed. So above all, the teachers' self-belief in molding that the students are very important. So let each one of us take a moment to introspect, try to become competent, to practice and follow these competencies, leading to expected professional qualities being followed lifelong to bring about the desirable change to fill the gap. Let us work towards the betterment of our students. Let us help all our students to shine the light and help them remove the darkness prevailing in the society. Thank you. God bless you.
I welcome Dr. Anita ma'am to felicitate our speaker. Please. Thank you, ma'am. Now I welcome Dr. Chitra ma'am, Anatomy ESI CMC PG IMSR Hospital, Nodal Hospital, Bangalore, for her presentation. Thank you. Thank you.
Good evening, one and all. Before I begin, I thank heartfully to the Almighty and the beautiful organizers here to given me an opportunity to share my experiences, my emotions, my thoughts on this stage. Thank you. So my topic is something professionalism reimagined in Gen Zs. So past 2 days, we've been discussing about Gen Zs. What is that we have to change for them as a teacher to teach the Gen Zs? So we know Gen Zs are those who are born between 2005, that particular decade of 2005 to 15. So why are we bothered about Gen Zs is that these are the group of students whom we are encountering with and whom we'll be seeing them as doctors in future. So we have a set of pictures as how a doctor should be, how a doctor in profession should be. This is what we see. But when we see the Gen Zs coming out as doctors, we are a little bit disappointed. I think everybody agree with this, especially when we are seeing the present generation Gen Zs, the way they talk, the way they dress, how they approach. That is why I think we are doing all this circus around the curriculum so that they can be remolded to get back into the profession, the noble profession as we think. And especially now, as we are going through, I think it is no more medical schools. It is going to become a medical factory. I think everybody will agree with me with that. So what is that? Are we prepared to take them? So have we understood what does professionalism really mean to the Gen Zs? Are we really prepared to take that group of doctors when we come to see them? Because we are the ones who will be seeing them. We are getting older, we'll get treated by them. So are we prepared to receive them is my question. I think everybody has this thought in yourselves. So what the reason why I got up with this topic was I have a kid, he's no more a kid, he's an adult who's in his first year degree. He had a project on taking words back or from his peers, pure Gen Zs, saying what is one thing you define about Gen Zs. The thing he came up was flexibility, adaptability, authentic. I was really awestruck when he said flexibility, adaptability. I think it is we who are adapting for them. It is not that they are adapting to us. And we are becoming flexible for them. So authentic, when they say authentic, I felt, yes, correct. What is that authentic means? They want to be themselves. So when we see them as doctors in shady dresses, uncombed hair later, then that is what we have to accept them, because that is what is Gen Zs. I think, yes, all of us actually, we are seeing them as such now also. So we are trying to remold them to our generation. So how much are we prepared to see them as they are authentic doctors? So what authentic exactly means is to take them as they are itself. So the way they dress or the way they speak, and they accept it also. They accept that I don't know. Whereas we are very inhibited to take that we don't know. We are a little bit egoistic, our generation. We cannot accept that we don't know anything. Whereas the Gen Zs are very cool. The cool attitude is that, okay, I don't know this. Okay, let me get back to it. Then is that fine with us? Is what is the contemporary education? Are we ready to accept that? Is it there as a part of a curriculum? We've been discussing wide and large about how should we be doing, what should we be doing. I think whatever we are doing is something like the newborn parents who are getting ready, the room to welcome a new baby. We are preparing everything. We are so making everything supportive to their growth. Every other aspect we see that they don't fall here. Everything is in their hands. They are, even before they think something, we are the ones who are getting it prepared. We are preparing ourselves as well as that particular generation to go on with a comfortable walk. But what is that later they see? And another concept I wanted to know, or the aspect I wanted to know, is the whole of the medical system, whatever we are doing, this particular system is preparing them for only this first 5 years. What after the 5 years? They come out as doctors. Not everybody comes back to the medical schools. We are all into the mainstream of medical education. That is why we know everything about in and around the medical education. What about those doctors who are there wide and large outside? How are they contributing for the growth of these doctors? What is their contribution in the society to bring up this particular group of students or the doctors? We don't know. That, I think, there is a lacuna for us to understand what should be done. What can we do for the wide and large, the doctors who are outside, who can help them, these particular doctors, to get adapted to the mainstream. Then this particular 5 years of their study, we are all acting as like the thymus. I think we are only giving them the primary education. As the thymus fades away, I think we are also fading away in their lives. Where is the secondary education happening? In the society, in the doctors who are not there in the medical education system, who should be giving them the input, molding them. I think that is where we are lacking. We should think about how we can bring or integrate that particular group of doctors within our medical education system to mold these doctors. So this is what my thought was. And thank you all for giving me this opportunity. Thank you.
Thank you, ma'am. Now I welcome Dr. Kartika Priyadashini, ma'am, Professor Physiology, Sri Venkateshwara Medical College Hospital and Research Center, Pondicherry.
Good evening, all. I thank you the organizers for giving me this opportunity. So I'm here to talk on assessment as learning. So we know assessments are of different types: assessment of learning, assessment for learning, and the new one is assessment as learning. What is assessment of learning? It is similar to that of our summative assessment, where we are going to assess the students at the end of the course or the program, which is of high stakes, where you're going to tell whether the student is pass or fail, or we are going to grade the students. It is usually done by a group of teachers or the faculties. Whereas assessment for learning, here it is the assessment which is done to make the students learn by giving frequent feedbacks, similar to that of our formative assessment, which is of low stakes. It enables the students to fill the gap and help them to improve. So that is assessment for learning. What is assessment as learning? So here we are using assessment to make the students learn. It is again of two types. We can divide it majorly into two types. It can be of self-reflection, or it could be of peer review. What is self-reflection? It enables the students to go and reflect about, as already said during panel discussion, what went well during the session or when the class was taken, what was difficult part for the student, and how to improve in learning those subjects, which the student found it very difficult. So in this way, by reflecting each and every class, it enables the students to improve by themselves. So this is one way of using assessment as learning, self-assessing. The next way is peer review or peer assessment, where the peers can be used or they can be motivated to become examiners to assess their own peers or the friends. So by doing so, the students who are acting as examiners, they can learn by seeing the mistakes of their own peers so that they won't repeat the same mistakes after that. So this can be implemented either in theories, like allowing the students along with the faculty to set question papers, to set the answer keys as well, or during OSCEs, allowing them to set the rubrics, the keys which has to be assessed for their peers. So in this way, by using the students or allowing the students to assess their peers, they learn by themselves. So these are the two main methods of assessment as learning. So what are the advantages of these methods? So it enables the students on autonomy. They are doing by themselves. It promotes self-regulated learning. Not only self-regulated learning, it motivates the students to continue to learn. So it promotes lifelong learning habits. Not only that, it enhances metacognitive thinking and critical thinking by going and doing and thinking about how they learned and what is the gap. It enhances metacognition. So these are the main advantage of using assessment as learning. So what are the main disadvantage of using these assessment as learning? The main disadvantage is cognitive overload. Every time in every class or in every subject, the student has to think about their own thinking, the way they think, the way they learn. So it could be a cognitive overload for the students. Or it can result in some effect called as Dunning-Kruger effect. What is Dunning-Kruger effect? There are different students, isn't it? So there are advanced learners and students who need additional curricular support. So when we use advanced learner as examiners, they over-assess. Or when we use the students who need additional curricular support, they under-assess the students. So this could be one disadvantage. Then there could be peer pressure for the students while assessing their own peers. And there could be also some interpersonal conflicts between the students. It could increase their stress and anxiety level. When we see from the faculty point of view, it would increase the workload for the teachers. There could be time constraint for the teachers or curricular constraint, which prevent them from using these assessment as a learning tool for the students. So this is what I want to tell, that what is assessment as learning and how it differs from other types of assessment. Thank you.
Thank you, ma'am. I welcome Dr. Ravindran, sir, Professor and HOD, to felicitate our speaker. Thank you, ma'am. Thank you, sir. Now I welcome Dr. K. Soundarya, ma'am, MEU Coordinator, Professor Physiology, for her presentation.
Good evening, everyone. So I'll not stand much between you and the valedictory function. So I'm here to talk on how we shall move from stations to stories. And it's high time we rethink our OSCE through integration. So let me start with a small story. So there is a patient called Mr. X in the medicine ward, and a second year student sees that patient as just a history of presenting illness related to the symptoms of tuberculosis. Whereas when he goes to the microbiology department, the same patient is just a slide number for him where he is assessing for the presence of AFB bacilli. When he goes to the pharmacology department, the same patient he's seeing as an arm of the mannequin where he is advised to give the intradermal tuberculin test. And in the Department of Community Medicine, he's just run statistics in the DOTS register and he's given how to give counseling. So at multiple points, at multiple buildings, multiple rooms, multiple time, a single student is learned, is given information, is being assessed at different points. So I have a question, whether the student is learning a book chapter, a disease, or he's learning about a patient. So it's high time that we step into something called as multidisciplinary integrated OSCE. In the panel discussion, they all expressed this as a major concern, that integrated assessment is a need of the hour. So let us take some baby steps. We'll try to select a module relevant to a phase. We'll try to integrate multiple disciplines. We'll select a disease and start assessing as a patient, and how the student is able to assess the patient as a whole by doing a hand rub, by doing a clinical examination. Before that, how he appropriately elicits the history. Is he able to interpret the AFB slide? Is he able to administer the mannequin? Is he able to give an appropriate counseling? Is he able to judge the treatment depending on the phase? So everything happens at the same point of time. So this is one beautiful example for integrated assessment. I know it is challenging. We cannot bring it as for summative assessment, but at least as medical educators, we can bring it as a simple formative assessment for a single module. Let us not make our students obese. Let us not feed them more. We will start with a small dose of medicine, start with a simple disease in a single phase with a simple module, try as a formative assessment, see the success. And all the best wishes for you all when you try this integrated assessment module. And I thank the organizers for giving me this excellent opportunity. Thank you so much.
Thank you, ma'am. Now I welcome Dr. Priscilla, ma'am, HOD and Professor of Physiology, to felicitate the speaker. Thank you, ma'am. Now I call upon Dr. M. Vijay Karthikeyan, sir, Associate Professor, Community Medicine, Vinaha Mission, Kripananda Vadiyar Medical College, Salem, for his presentation.
So good afternoon all. At the outset, I would like to express my heartfelt thanks to Dr. Prabhakaran sir, Anjana madam, Priscilla madam, and all the organizing team members of DEEPAM Medicon for giving me this wonderful opportunity to speak in front of this eminent crowd. So I would like to start my talk. The topic of my talk is team building in medical education from solo to synergy. I would like to start my talk with the words of Henry Ford. Coming together is a beginning. Keeping together is progress, and working together is success. These words exactly reflect what is the journey of the medical students in our medical institutions. So on day one of the medical school, the students enters into a individual, and over the years he progresses into an highly competent clinical professionals through our medical training. So in medical education, we mainly make our students to perform as an individual and excel in their exams with high marks and excel in their assessment. But actually, what is the main irony is that in real life situations, they can't act as a single person. So where teamwork is what gives us more outcome, and a solo player can't perform his skills to the level of a synergistic or a teamwork person. So I would like to highlight here that the patients whom we are going to treat, they're least bothered whether we have topped the exam, we have scored high marks or low marks in the exam. Ultimately, what they want is that whenever they visit a hospital or a healthcare institution, the healthcare team has to make sure that their pain and suffering is alleviated. So here the prime focus of this integrated as well as the synergistic approach comes into existence. Though we follow this solo approaches, there are so many errors that might occur, and also the students might go in for a burnout. Burnout will definitely creep in, and also communication breakdowns will be there. So ultimately, we have to concentrate on a synergistic learning approach. And over the years, if you take the medical education has evolved, and we as a teacher, we have moved from solo teaching, individualized teaching to an integrated approach. And also, mainly we want to follow a integrated approach due to this rapid evaluation of our curriculum, due to the paradigm shift of introduction of this CBME curriculum, there are various avenues for the students nowadays. So, and also they have to, an Indian medical graduate has to attain so much of skills. They have to get attain their certifiable clinical skills, communication skill, leadership skills, and also problem solving skills. So many skills they want to explore, and this can't be done with a solo approach. And there are various avenues in the curriculum itself for this synergistic approaches. Say, for example, the early clinical exposure, the integrated teaching, both the horizontal integration as well as the vertical integration. We have this family adoption program where the students learn so much in this family adoption program, and also elective postings. These are various avenues where this synergistic kind of or an integrated kind of approach can be tapped. And always synergy, what exactly synergy means? Synergy means strength. Synergy means a combined effort. And synergy means a cooperative responsibility. So we want our students to master in the skill of teamwork. And teamwork is not, it's not considered as an extra skill. It is a mandatory clinical skill that each student must master. And we as a teacher, we have to make sure that our role has transformed into an mentor as well as a facilitator. So we have to make sure that we inculcate the skills, this teamwork related skills from early part of their career itself, so that the ultimate aim of good patient care and outcome can be achieved. So I would like to end my talk by putting important thing. That is, whenever we go back to our wards or classrooms, we have to just remember one important word that was said by Charles Darwin. That is, change is inevitable. So we have to make sure that we change from the approaches of me to we, and also we have to make sure that the students nowadays move from this isolated kind of approach to a synergistic and collaborative approach. We have to make sure that we have to encourage our students to compete in classroom, whereas collaborate in the wards. So I would like to end by saying that let us all join hands and let us be the change and also make the change. Thank you for this wonderful opportunity. Thank you.
Thank you, sir. I request Dr. Manveri ma'am to felicitate our speaker. So kindly accept a token of appreciation and love. Thank you, sir. Thank you, ma'am. I now welcome Dr. T. Dinesh, Associate Professor, Department of Physiology, Government Medical College, Nagapattinam, to deliver his Ignite talk.
Respected dignitaries, today I'm standing before all of you to share my thought. Disclaimer, this thought is only belonging to me, and I thank the organizing team to share this thought in this expert or important stage. Outcome is clearly articulated, rarely or less satisfactorily actualized. This is my topic. Now, I have to justify this, why I came to this topic. I randomly asked one of my students, what is outcome? Outcome na ennapa? He told, outcome வந்து தியரி கொஸ்டின் பேப்பர் யூனிவர்சிட்டி சம்மேட்டிவ் எக்ஸாமில் ஒரு ஷார்ட் நோட்ஸ் மேண்டேட்ரி. அது வந்து ஒரு 3-4 பேஜஸ் எழுதிட்டா வி வில் கெட் 5 மார்க்ஸ். உனக்கு யார்ப்பா சொன்னா? இல்லை சார், சீனியர்ஸ் சொன்னாங்க. அப்படியா? செஷன்ஸ்லாம் எடுப்பாங்களே, அது எடுப்பாங்க சார். ஏன்ப்பா அதெல்லாம் அட்டன் பண்ணுறது இல்லை? இட் வில் பி போரிங் சார். ஐ வில் நாட் பி இன்வால்வ் இன் தட். என்ன பண்ணுவேன்? ஐ வில் பி ரீடிங் இம்பார்ட்டன்ட் டாபிக்ஸ், யூனிவர்சிட்டி கொஸ்டின்ஸ். அந்த அட்டண்டன்ஸ் கூட அது யாரும் பெருசாக எடுக்க மாட்டாங்க சார். தியரி ப்ராக்டிக்கல் தான் எடுப்பாங்க. ஸோ திஸ் இஸ் த ஒன் which I wanted to identify the gap. Actually, there is a gap which is existing. Now I want to put it in 3 things. So this gap exists because of 3 reasons. One is problem at the system level, faculty level, and student level. What is the problem at system level? At system level, there are a lot of issues are there. One thing is, we have not touched all the faculty members for BCME even now. So lack of adequate training, and many colleges are conducting frequent FDP programs, and some colleges are giving excellent training in the humanities, as madam also told, but it is not uniform. It is not uniformity, and there is no proper assessment. There is no proper assessment, and monitoring also lacking. And NMC has suggested only minimum faculty, but nowadays in many places there is faculty shortage. This is a problem to be corrected by the system. Now, what is the problem at system level? I mean, faculty level. At faculty level, the problem is the mindset of the faculty. So one thing, we have not trained the faculty, so they are not having adequate training, and they are not convinced. They are unconvinced about taking the sessions, and they don't have proper justification how I am going to do this, in what way it is going to help them, and some are having resisting mindset. ஸோ அட்கம்லாம் எதுக்குப்பா டீச் பண்ணிட்டு, அவங்களே கற்றுக்குவாங்க, நானாக என்ன கற்றுக்கிட்டா வந்தேன். ஸோ திஸ் இஸ் த மைண்ட் செட் விச் இஸ் ஆல்சோ தேர், விச் வி cannot ignore. This is second thing. Third thing, at student level. So at student level, the problem is the exam-oriented learning culture is there among the students. So if it is important in the exam, then they will learn. That is why NMC has mandated to be asked in the theory question paper as short notes at least, so that they will learn. And it has been mandated in various logbook as well as portfolio, they have to document it. But actually, how it is practiced, the one example I told. So that is one problem. Second thing, students feel uninvolved or disengaged with the AdCom sessions. They feel bored because the delivering point that we are lacking. So they feel we are repeating the same, so they feel bored. That is another problem. And third one is they don't have the ownership. There is lack of ownership on the part of the students. So it is for them. We are teaching them to become a good doctor. So that is not there on the part of the students. So this lack of ownership is another problem. So we all need to remember that NMC has introduced AdCom as a longitudinal module to be taught throughout the curriculum. And most of the time, the AdCom sessions are taken for namesake or less frequently conducted or omitted. Whenever we want to adjust the syllabus, the first thing we are going to adjust is AdCom. We are, for example, due to cultural or local holiday, rain, whatever it is, if there is lack of any hour, we will compromise these AdCom sessions. So that is there. So these things need to be avoided. So this is my thought. And we all need to remember that we are all going to practice medicine. Medicine is an art and it is not a trade. Even for trade, ethics, professionalism, humanities, everything is there. And we should not forget that. To conclude my talk, I want at system level, at student level and faculty level, the changes need to be done. And at least in the near future, we will all produce doctors who are going to fill up these gaps. Thank you very much.
Thank you, sir. I now welcome Dr. Vanilla ma'am from pathology to felicitate our speaker. Sir, please. Thank you, sir. Now I welcome Dr. Hemavati Ramalingam ma'am, Senior Assistant Professor, Department of Physiology, Government Vellore Medical College for her Ignite talk. Welcome, ma'am.
Respected dignitaries, honorable senior professors, and distinguished panelists, my pals and my beloved children gathered here in this gorgeous institution. A very pleasant good evening to one and all. Me, Dr. Hemavati Ramalingam, Senior Assistant Professor of Physiology from Government Vellore Medical College, is going to ignite on the topic Words That Heal, Why Communication is a New Core Competency. Firstly, I would like to enlighten this topic from the Tirukural Bulletin, where the first poet has tributed in-depthly about communication. So he says that when pleasant, sweet words are available, why choosing harsh words? Similar to that of choosing an unripe fruit instead of a ripe fruit. Now, let me put forth a question here. Have you ever been hurt? Not by the weapon, but by the words. Have you ever felt comfortable? Not by the medicines, but by the soft spoken, kind words. You all know that in this global civilization, in this recent trending technological world, we all of us are surrounded with AI that assists diagnosis, technology that operates and monitors patients, chat GPT, which answers all the questions you asked by one and all. But what is the biggest crisis that is lacking? It is not the knowledge. It is the understanding, listening, empathy. So here comes understanding, which is the
precise tool and a single skill, that is communication, which is the survival skill, leadership skill, and life skill. We also live in a world of short messages, emojis, social media fights. So what do we do here? We just scroll the messages, shorts, reels. We never listen. We fail to listen completely and reply quickly. And here comes the scenario of miscommunication and misunderstanding. So thereby what happens is the families break, students suffer, society loses its toxicness, and the team loses its dynamic activity. So here comes a saying, speak to make healing, not to provoke a point or prove a point. And also, this communication is not a professional communication. This can also be said that it is biological. How? From my subject, from physiological perspective, I would like to put forth about fight or flight response, which is mediated from the limbic system, hypothalamus, sympathetic axis. What does this mean is when you become anger, your BP increases, your heart rate increases, and our words, we lose our words. So thereby what we scream, we shout. So thereby, that is why, again, I would like to remind about Thiruvalluvar, who has quoted exotically and explained beautifully about soft-spoken words that can heal, why communication is a new core competency. What he has said is, the wound that caused by fire can heal, whereas the wound that is caused by words can never heal. That is why, henceforth, we must always remember words can heal, words can harm, words can build a person or break a person. That is why the doctors, as doctors in the future, we should be communicably confident, emotionally intelligent, and clinically competent. There is also another saying, words are valuable and they are priceless, though they are free. What does this mean is, when you talk, when you interact, leaving all your gadgets, when you sit in a gathering, you become to learn, you know to learn many things from all these words. So last but not the least, I am here to conclude and thank everyone for giving me this opportunity. Thought for the day is, we use our stethoscope for listening the sounds of the heart. We attitude ourselves to influence the brain. But it is only the words, the voice modulation, the tone of us which can heal, which can explain, which can comfort and reassure the humans. Thank you one and all for this opportunity.
Thank you, ma'am. I welcome Dr. Viji ma'am and Anuja ma'am to felicitate our speaker. Thank you, ma'am. I welcome Dr. D. Ashwini, Senior Assistant Professor of Physiology, Government Villupuram Medical College, for her Ignite talk.
A pleasant good evening to one and all present here. I'm Dr. D. Ashwini, Senior Assistant Professor, Department of Physiology, Government Villupuram Medical College. I would like to begin my talk with a bitter truth. If listening to 1 full hour is medicine, then most of the medical students will stop listening due to the intolerable side effects such as sleeping, yawning, and boredom. Because the maximum attention span for most of the students and for most of the faculties would be somewhere between 20 to 40 minutes. And for today's Gen Z kids, it's even lesser than that. So if I am supposed to take a lecture of 1 hour, I do not ask myself, how do I teach more? I ask myself, how do I keep them alive and awake mentally? So that is how my burst strategy was born. BURST. B is to begin, break and begin. U is to unpack and make them understand. R is to revise and recreate. S is to summarize and stimulate. And T is to test. Starting with the B of my burst strategy, I begin my session with a set induction, either a short story or a relatable clinical scenario or a relatable life experience. In doing so, I capture the attention of my students, I activate their knowledge, I create a curiosity. This even before the content is delivered. The students feel as though they are entering into a conversation rather than they are entering into a lecture. After about 20 minutes, say 20 minutes, when the attention naturally dips, I consciously break my sessions. So in a 1 hour lecture, I have 3 short, purposeful breaks with set inductions and clear objectives. So these breaks are not a distraction. They are a reset. They are a bridge back to learning. My first break is actually a social and emotional reset. I simply ask my questions. What did you have this morning in the breakfast for the breakfast? What was your physical activity? Who was the Big Boss title winner? What are the weekend plans? So I also narrate a 60-second short motivational stories. And I also recite some interesting college stories of my own. So the moment the classroom changes, students giggles, smile spreads. At that moment, I am no longer a teacher. I become more relatable and teaching becomes more effective. After this break, the second break is a cognitive and physical reboot. This is actually a movement break, which most of us do in our classrooms, make them stand up, move, lift their hands up, put their hands down, some box breathing exercises. Apart from that, I also teach my students kindergarten rhymes. Kindergarten rhymes, most of the students will be knowing, but I teach them with beautiful actions. Supposing Johnny, Johnny is Papa. In a classroom of boys and girls, I divide boys and I tell boys they are Johnny and girls will be Johnny's Papa. So I teach them rhymes saying Johnny, Johnny. Girls will say, looking at the boys, and boys have to keep their hands like that and say, yes, Papa. Girls will say, eating sugar. Boys will say, no, Papa. Girls will ask, telling lies. Giggling. Next, I make them play simple Ringa Ringa Roses game. Ask boys to make a greater circle. Girls will be forming a lesser inner circle. Hold the hands, swirl around, sing Ringa Ringa Roses, and finally they fall down. And of course, fire in the mountain, everybody rose. Fire in the mountain, they will be running. And I say a number 10, they go and form a group of 10. And some color games. I choose different colors. I stick in the 4 corners of my classroom. Music will be played on. We have small Bluetooth speakers, so I will switch on the music. Students will run about. I'll stop the music. Students will stop across certain colors. Randomly, I call out the name of the colors. Students will be saved or students will be out. So doing such things will increase the cerebral blood flow, improve the cardiac output, reduce the fatigue, improves alertness and active participation. My third break is, of course, for attendance. Next, after breaking, moving on to the U of my burst strategy, which is unpack and make them understand. So I will unpack the complex processes into simple, logical, and visual cues. I will explain each and every event in sequence rather than teaching everything at once. I will also convert the abstract processes into simple timelines, graphs, and flowcharts. In doing so, our unpacking makes any subject easily understandable, helps them in meaningful understanding rather than meaningless memorization. Moving on to the R of my burst strategy. After unpacking and after breaking my sessions, I revisit the key points. Revision in my class is not repetition. It is just revisiting the key points just by eliciting response for the students. I elicit the response by asking them to just look into the key points of the 1 hour lecture and draw a flow chart, draw a graph, or also do a role play. When students recreate, passive listening becomes active learning. When students recreate, they own mastery, they build mastery. Next is S and summarize of my burst strategy. Where I ask them to summarize. Summarize can be either a 60-second summary by a single student or a group of students taking 3 take home messages, or every bench giving a quick one-liner. Doing so will surface any misconceptions, will reinforce the subject again and again, and teaching will become more student-centered rather than teacher-driven. Finally, T is test. I would test my students with many learner-friendly techniques. Either we play connections, we play crossword puzzles, we play like Educa Play and all those games. But testing my students is not judging them or is not to create fear. It's a way for collecting the feedback from them. When testing becomes enjoyable, curiosity replaces fear and learning becomes effective. So in this process, my classroom becomes a place where students move, students smile, students speak, and of course, students learn with joy. So teach less, engage more, and learning will burst. Thank you.
Thank you, ma'am. I request Dr. Isai Priya ma'am and Naurang ma'am to felicitate our speaker. Thank you, ma'am. I welcome Dr. M. Shaktivel sir, Assistant Professor, Community Medicine, Meenakshi Medical College and Hospital, Kanchipuram, to deliver his Ignite talk. Okay, sorry. I welcome Dr. Prasanna sir, Assistant Professor, Pharmacology, Government Medical College, Virudunagar, to deliver his Ignite talk.
Greetings, Meded Mastros. I'm Dr. Prasanna, inviting you on this reflective journey in finding where we, as teaching faculty, are in the ringmaster, acrobat, and jester spectra when it comes to our learner interactions. So here is our character intro. First, we have the ringmaster persona who has a hierarchical mindset with their own prejudices, hunches, opinions, and guesses. And they think knowledge is a commodity to be transferred to the learners. They know the learners only as roll numbers, and they use cynicism to avoid accountability for a holistic learner growth. Next, you have the jester type faculty who are like friends or quasi-parents to the learners, 24/7 spoon-feeding them, trying to internalize their learners' academic failures as their own, and they are too nice of a teacher to discipline their students, and they go overboard in granting them favors, all at the expense of their own burnout. Next, we have the acrobats, a balancing act across the tightrope. The acrobatic style teacher grows along with the learner by role modeling positive behavior, and they provide a psychological safe space for their learners to discuss their issues, but also know when to refer them to consultants because they know one mentor can't do it all. They gray rock and compartmentalize the learner's issues from their own, and they also know learning is the sole responsibility of the learner and that the learner's academic failures do not reflect on them. In short, they are fair to their students, meaning they provide a timely, consistent, constructive feedback. They allow active participation of the learners in the study process because they know a sense of relatedness will increase the intrinsic motivation to learn by the learners as per the self-determination theory. And they know the learners as individuals who have their own learning styles and needs, maybe even use the biodata forms to get familiarized with them, and they set relevant goals for the learners to achieve. Let's see a few scenarios where all these three, how they interact. So regarding mentoring, the ringmaster says, I give high challenges, but only low support to my learners. They seem to regress. And I practice teaching by humiliation. And frankly, I hesitate to mentor the opposite gender. The jester says, I give high support, but only low challenges to my learner because I don't want to give an honest negative feedback. My learners seem to be in a stasis mode. We have the acrobat who says, I recognize my learners' zone of proximal development. I give them both high challenges as well as high support, so they seem to grow. And also, I establish a firm, stricter boundary at the term beginning so that they know what to expect from me throughout the term. Next, regarding a disruptive classroom behavior, the ringmaster says, I'll ask them to leave the class, I'll yell at them, I have a zero tolerance policy. The jester says, even if they are going to use their mobiles or going to sleep in class, as long as they don't disturb the class, I don't have an issue with that. Next, we have the acrobat who says, I practice empathetic discipline because I want to repair the harm, not to assign the blame. So I'll ask the student to summarize the points of the lecture. And after the session, I'll have a discussion with them to know the why behind their behavior. The third scenario, outside classroom access. The ringmaster says, it's not required, but if they don't wish me in public, I will take offense. The jester says, I grant them unlimited virtual access 24/7. The acrobat says, I'll provide online clarification within 24 hours. For non-emergencies, no access outside office hours, but I'll maintain consistent office hours. And I might accept the friend request from a passed out student, maybe. And I will practice a mindful pause before posting anything in the social media, which is a shared space with the students. Besides, I am authentic enough to be unbothered if my student doesn't wish me outside class. Now, here are my few humble tips to get ourselves more acrobatized. Hand out Mentor of the Month awards like in the IT functions at department level or institution level functions. Have an online mentor networking, a very good online mentor networking, and offline periodic meets with senior mentors who can give us clarifications on how to act. Still, we should behave and we should maintain the students' confidentiality and anonymity definitely in those forums. And then we can have workshops on this and sensitize our faculties regarding that. And still, even with all this, we can have even OSTEs, objective structured teaching evaluation exercises for teachers, have an expert faculty committee who can decide on the student boundary interactions with institution-specific scenarios. But still, we should know we will get entitled, pushy, non-compliant learners. And as acrobats, we must know to flexibly switch back to a ringmaster, but only as a last resort. In a nutshell, let's ask ourselves these three questions. Am I serving my own needs at the expense of students' welfare? Am I serving a student's expectations at my own expense? Am I compromising my ability to evaluate the student in an objective manner? And let our answers to these be our moral compass. Thank you.
Thank you, ma'am. I now welcome Dr. Punita ma'am and Gayatri ma'am to felicitate our speaker. Ma'am, please. We now welcome Dr. K. Kavita ma'am, Senior Assistant Professor Microbiology, Government Medical College, Karur, for her Ignite talk.
So my topic is the faculty effect, the unparalleled driver of professional identity formation. So respected seniors and my dear friends, we all would remember the day when we received our first white coat. Yes, do we remember? Yes, so it was stiff, bright, and if you would admit it honestly, it felt just like a costume. Over the year, we memorized anatomy, but we were still to hold of the soul of a physician. In today's world of medical education, we talk a lot about entrustable professional activities, OSCEs, and assessments. But the most important transformation that a student undergoes is not the acquisition of the knowledge, but the professional identity formation. What is that? It is the shift from doing medicine to being a doctor. And the most powerful and unparalleled driver of that shift is the faculty effect. We all would agree when I say that you do not remember any of the lectures that you hear during your medical college days word by word. Yes? But you still remember how a teacher doctor talked to a patient, how a mistake was managed, how a junior was handled in the public. These moments stay with us. This is the faculty effect, the silent curriculum, the curriculum which the teacher teaches even without realizing that they are teaching that curriculum. Okay. And that is the most important curriculum in today's medical education, the curriculum which is never written, never timetable, and nor assessed. Research says that professional identity formation is not formed after an hour-long lecture on ethics. It is formed from micro moments in the wards. The way we sit down to talk to a terminally ill patient, the way we react when something goes wrong, the way we manage uncertainty when we don't hide behind authority. These are the micro moments. And as faculty, we are the walking and talking curriculum. When the learners observe us, they'll not only learn the art of medicine, but they also learn what it is to shoulder responsibility. And this is the faculty effect. Nowadays, we ask very difficult questions like, why does empathy decline over the professional clinical years? And why is professionalism so difficult to teach to undergraduate medical students? The uncomfortable answer is very, very simple. The students do not do what you say. They do what you do. Consider a situation where the consultant is doing his routine ward rounds and the patient asks a very sincere question. And the consultant replies that, you need not know about this. Just trust your doctor. No lecture on communication can undo this moment. The student learns that it is okay to put compassion behind authority and it is inconvenient to ask questions. So there was nothing formally taught in this situation, but everything was learned. According to Crues and his colleagues in academic medicine, professional identity formation is formed from socialization, role modeling, and social networking. With this framework, I propose a simple lens. It is the mirror and the bridge effect. As faculty, we mirror what it is to be a doctor. When the learners observe us, they not only learn the art of medicine, they also learn how we behave, how we doubt, how we decide, and how we talk to the patients. Long before professionalism is taught to the students, it is caught from us. So we are the persons who are giving the what is professionalism to these students. I once remember an intern who asked me a question during my routine microbiology reporting. I'm a microbiologist. She asked me a question for which I did not know the answer immediately. So I just looked up at her and I told her, I also do not know the answer for this. We will look up at the answer together at the end of the session. So by the end of the session, we did look up at the answer together. In the end of the post-its assessment and reflection, she had noted this particular moment and written that this moment gave her the confidence that it is okay to ask questions and it is even much okay to accept that you don't know. So this moment was never formally logged or assessed, but it was deeply formative. I think many of you here can quote such instance from your long teaching experience, which parallel my emotions at that time. As faculty, we are not only the mirrors, but also bridges between the competence and the identity. And how do we build this bridge? We build this bridge when we invite reflection, when we explain why a moment matters. Sometimes a simple line, just observe what happened here, is going to do much for the professional growth of the student. So as faculty, what should we do now? We have to make 3 simple shifts. 1, pause before you react. The learners are always watching you.
2, make the invisible visible. Name your emotions so that the students understand. 3, create psychological security. Learning thrives where fear does not. So to conclude, every war room is a classroom. Every conversation is a lesson, and every teacher is teaching whether he's willing or not. The most important curriculum in today's medical education is not what is written in logbooks or guidelines, but it walks down the corridors with us, constant, demanding, it unforgettable. Let me leave you with one question for all of you to reflect upon. When the learners watch you tomorrow, what kind of doctors are you silently teaching them to become? Let's reflect on this. Thank you so much for this grand opportunity.
Thank you, ma'am. I request Dr. Yoganand sir and Dr. Gautam sir to felicitate the speaker.
Also, Dr. Vinodini.
I now welcome our chairperson, Professor respected Dr. Kavita ma'am, Dean KMC, to grace this occasion with a few words.
Yes, a very good evening. Thank you for this opportunity. My hearty congratulations to the DEEPAM iMedicon, which has done a wonderful job. And definitely all of them have ignited, I should say, each speaker has been unique in their thoughts and what they have presented. Some of them have been with respect to certain aspects of medical education, and some of them have been just general things, of which I would like to say of special mention is Dr. Prasanna. I think the acrobat, all of us should try to become the acrobat. And the burst technology that was told, I think if everyone follows whatever she said, all the students will be really very well engaged actively in their things. And I would like to thank Dr. Raghunandan sir, Dr. Ravindran sir, who are my mentors who are here. Thank you, sir, for putting me into this medical education, both of you. And Dr. Chitra, I'd just like to tell something. She was talking about the Gen Zs, and I appreciate her thought on the secondary education, where the students, after completion of CRI, they go into the society, and whether they are taught and molded in that. But at the same time, I'd like to make some observation like the same Gen Zs who are taking other subjects like nursing, not a single person is without an uniform or an ID card or a properly, they don't comb their hair, all these things. So in that, I would like to say whether we as faculties are failing in our duties, like the first speaker said, if we have the discipline, integrity, commitment to excel, I think it is in ourselves that we should inculcate in our students, and we should be a little more demanding as what should be done. And the speaker who talked about ATCOM, Dr. Dinesh, he was very realistic what it is on paper and what we are doing. I think it should be as a regular practice that we do this ATCOM in every class. As Dr. Kavita said in the last speaker of microbiology, the students look upon as whatever we do, what we say, how we talk, how we speak, everything. So we should be very careful of what an example we are setting, and all of us are role models to whichever student. And keeping them more actively engaged is really something that all of us should look forward. And I congratulate each of the speaker for whatever they have done, and I'm sure they would have ignited many minds. The multidisciplinary integrated assessment, which was talked about even during the panel discussion, I think that's very much feasible. Also, which we can practice. We did it and we found it successful. It can be done by anybody, just that we have to motivate them. And I congratulate the whole team for such a wonderful program. And this special thing, and of course, Dr. Kribakaran, Dr. Anjana, Dr. Sangeeta, all of them have added more spice to this particular program. I congratulate each one of them. Dr. Sangeeta, Dr. Priscilla from Thiruvannamalai, you have done a very, very great job. And to see all of them waiting here till this end, it's such a joy to always be a part of this conference. And I think special mention should be made about Dr. Shantaram, who has been the core person, who has been the reason for this all happening in each of the zones. Like, so thank you all. Thank you for this opportunity.
Thank you, ma'am. Thank you for your graceful words.